Hello, welcome back. I hope you're well. It's Jill here. We are in the sunny East Nuke where, it still hasn't rained. I realise I give a weather update every week, but normally we do get a moderate amount of rain, and as it just hasn't rained since the beginning of March, it's all become a little odd. Anyway, I'm sitting in a field watching some swallows and some house martins busily gather things for their nests. I'm not very good on bird song, but perhaps you know what that bird is behind me. So today's guest is Dr Hussain Al-Zubaidi, who you may already know if you're working in the world of physical activity, but he is first and foremost a GP, but he also works across Parkrun and Red Whale, and he is really passionate about physical activity and lifestyle medicine. So today there's a lot around social prescribing, around how health professionals can change the story on aging and strength. There's actually loads in here. It's a really fascinating chat. So we'll jump on in and I will be back at the end.
How to stand on shifting sand. How to bend but stay intact.
Okay, Dr. Hussain Al-Zubaidi, thank you very much for coming today. I really appreciate you giving us your time. I think a lot of our listeners will already know who you are, but for those of them who don't, I was just wondering if you could tell me who are you and how did you get here?
Hi, Andrew. My name's Hussain. I got here through meeting yourself at ActiveNet conference, which happened in Crieff in Scotland.
That's right.
And it was an incredible session where you kind of redefined a little bit about what movement was for me. And for me, it's been another step in many stepping stones of my own journey in sort of shifting perspectives when it comes to movement. And I'm a GP by background. Nowadays, I kind of see myself as a real advocate for movement within healthcare, in particular primary care.
Great. Yeah, I think, and as I said, I think a lot of people will know who you are. And I think a lot of people will know that your relationship with movement and physical activity really changed, I think, as you were maybe finishing up university or an early med student. So if you could just talk a little bit about your background with physical activity and maybe beliefs that you had growing up and how those beliefs shifted and changed the way that you thought about yourself, the way that you thought about movement.
Yeah, I think when I was a kid, I was quite hyperactive in the sense that I love to move. I always like to explore things, but for my parents, I think it was hard work
Yeah.
because they constantly had to sort of chase me down, and they had a real focus for academia.
Hmm.
Given their background, they'd immigrated to this country. Life was very tough financially growing up, and so they wanted us to be secure. They wanted us to be stable, and they saw academia as the sort of safest way to do that. And I remember distinctly, I think I was in year two, but I got severely told off for playing football at lunchtime
Wow.
with my friends because I wasn't revising, because I
Yes.
wasn't working to excel academically, to continue doing stuff. I got banned from going to football clubs or any sport clubs, and so I was always told, growing up, that uh, you know sport, movement, it was all things that that was leisure. That was, if you had time and had space, yeah, great,
Hmm.
maybe. But priority is to focus on building a life and a career, and building up safety. And I totally get why, given the experiences that they went through. And that meant, as I sort of went into sort of teenage years, I very much fell behind when it came to sport ability. So the rare times that I would engage, I'd be terrible. So I was always picked last, as you would. Any sensible person picking wouldn't pick me. I wouldn't pick me. And it left us a very negative perception of movement, of physical activity. I felt that I wasn't particularly naturally gifted at it. And through university, especially in the initial few years, where a lot of people really, really engage in a lot of sport, especially on the Wednesday afternoons, at least that's what we had for our Wednesday afternoons, I just wasn't. I wasn't that way inclined. And it took myself being diagnosed with something called non-alcoholic fatty liver disease,
Mm.
although it's now got a new term for the sort of the sharp clinicians amongst us. It's now called MASHOLD, metabolically associated steatohepatitis of the liver. And that was due to the fact that I'd gained a lot of weight. I'm about maybe 25, 26 kilos more than what I am now.
Wow.
And it was the wake up call, because there was no other path apart from worsening liver fibrosis and then cirrhosis. That was the only path that I would go on if I continued living the lifestyle that I was. And so that triggered me to want to explore ways to get active, but it was difficult because I had no easy method of doing it. I was really physically illiterate. I just
Mhm.
didn't know what to do, how to do it, where to do it. I didn't even know what to wear. When I attended my first ever park run, I didn't have any trainers. I didn't own trainers. I just wore a really old shirt and a kind of a jogging bottoms, which I normally wear for painting.
Yeah.
So I don't know what I must have looked like on that first ever park run, but yeah. So to put it mildly, my perception of movement has rapidly changed from that point, which is what now, I think 11 years ago, something like that.
Okay. So that was really the turning point for you. Was you found some trainers to run in, and you went and you tried out a park run.
Yeah, that's exactly. And that first one, God, it was so difficult.
Yeah.
It was so difficult, even just to go. In the first instance, I was thinking of so many different reasons why I shouldn't go.
What was the impetus for going? Was it somebody you knew? Did you get an invitation? Did you just see that there was a new park run that was opening?
It was the fact that I attended a lunchtime meeting at the practice that I was in,
Mhm.
and the local parkrun event team was doing a presentation about parkrun. And two of my colleagues were keen park runners
Mhm.
and knew the event team quite well. They'd been going for a few years, and they they encouraged me, saying, "Oh, why don't you come along? We're going to go this Saturday. I think you'd like it." And my wife actually had started running for about a year and a bit. So I kind of thought that, oh, she hasn't heard of Parkrun.
Yeah.
She just runs on her own.
Yeah.
Maybe she'd like to go. So I thought, okay, let's just see if she'll enjoy it. I'll go just because, I wanted to feel part of the community, because
Mhm.
when the local event team presented to us, they really highlighted that, the fact that it was a sort of a meeting point for the
Mhm.
community, and it was just a great way to start your weekend. And so I thought, oh, okay, worst case scenario, I'll go. Probably maybe not finish it, but I'll just go and just get the vibes and just
Yeah.
do a little bit of movement, see where I go. Shanaz, my wife, will probably love it. And so that was my first sort of thought when they brought it up. I'm so glad that they did.
Yeah. And that's amazing. And did you say that was 11 years ago now?
Yeah, it must have been, like, what was it, 2015?
Okay.
So
Yeah.
20, so
Yeah.
about 10 years ago.
Yeah. Math checks out. Yeah. All right. So, you did your very first park run, 5 kilometers. Obviously,
Mm.
really hard. The sort of thing that most people won't be able to do without a little bit of training. Obviously, you have all the couch to 5K programs to help people get up to that point where they can really participate. By running for the full 5 kilometers. Must have been very tough for you. But flash forward to present day. So where are you now? What does your relationship with physical activity look like nowadays?
Yeah, that's a really good question. What is it? It is a part of me. It is something that I no longer consider a chore
Hmm.
or a necessity. Because back then, I wasn't enjoying it, but I was doing it because I needed to. I want I the pain of the activity was less than the pain of thinking that my liver was going to pack up.
Yes.
And then over time, and it took a fair bit of time. Like, we're not talking about months, maybe a few years. My opinion just shifted as I was no longer as worried with regards to the liver, because I was losing weight. I was seeing in the ultrasounds and the blood tests that were being done that it was improving. I then realized that even if I didn't have this issue now, I wouldn't even want to dream of a
Mhm.
day where I couldn't find an opportunity to be active in some way or form. And now it's my way of just finding out a bit more about myself. I think that's the thing. Like, that's what I love most about the different forms of physical activity that I've done. I've learned so much about who I am,
Mm.
the strengths, the weaknesses,
Yeah.
and everything in between. And I just feel like movement can be such a great way to discover things that you'd have to pay hundreds of pounds from a therapist to work out about yourself.
In the story, I was thinking about it. In a way, you were probably set up for success more than a lot of people are. And what I mean is, as I hear the story, you have a wife who's already running. You're part of a practice where you're introduced to Parkrun. I suspect you probably had colleagues who could contextualize the physical activity. When someone told you that you had fatty liver, you understood the implications of it. So you were sort of this environment where you know you probably had a better chance than most people. And that's not to dismiss your accomplishments, which I think are great, and the consistency, and I think what an amazing advocate you've been. But if we look in the other direction, what are some of the barriers that the average British person who might be in a similar situation to where you were 11 years ago, but take away the med school, take away the partner that runs, take away the sort of, like, I don't know, the salutogenic environment of being in a practice with other doctors.
Mm.
How how do we take that, and how do we make that accessible to the average British person?
Yeah, it's spot on. And you're absolutely correct. And those key elements that brought me the steps that I needed to get to the top of the mountain. So basically, there were ladders that enabled me to do those steps rather than to have to hike it all up on my own. And that concept of creating ladders is what the sort of the lifestyle clinics that we run at my primary care network, Leamington Spa North, with an awesome team that we work together, is we're trying to create those ladders. So, you mentioned, for example, understanding and appreciating the impact of the condition that I had because of my medical background. That's something that we try to do with the different long-term conditions. Give them knowledge, give them that information so that they can feel more empowered about the choices they make. You also mentioned about the importance of having the local parkrun event there to sort of help me, to sort of give me that familiarity before attending. And so we will invite a number of different physical activity providers and sessions to build up that awareness so they can feel comfortable, confident with the various different forms of activity they may want to engage with. And we have walking and running and swim groups designed to improve their literacy, not even as a workout.
Yep.
We probably don't, burn much energy there. But what we do is we just give them confidence moving again. And then that will naturally mean that they're just feeling in a better place, more activated to take on maybe that dance group, or maybe taekwondo, or maybe something else. And so that, plus a number of the other measures, is I think what's so important is, how do we create an environment where the choice that we want to make
Yep.
is as easy, as frictionless as possible. Now,
Yes.
you can do things to bring the ladders. However, no matter what you do, some people will always have further to go than others. And I think appreciating that and getting the individual also to understand and appreciate that is so important, because they may look at, for example, someone like me and think, oh, he's so good and, he managed to do it, but I'm not able to do that.
Mm.
Well, we are unlikely to have started on the same place.
Yes.
And so we try to get people to focus just on themselves and appreciate that we've all got a different journey to go on. And we're going to try our best to support you on that journey as far as we can. I think a really important element, how you mentioned about my colleagues, and they were a key element and my wife, to give you that kind of community. Those around me were being active and enacting that behavior. I was therefore able to feel connected with them. That was one of the real positives. And so by having these groups, and therefore the regular walk groups that then get connected, in the run group and the swim group connected to the sessions, they will also meet like-minded patients that are also on that same journey and doing the same process. And these things don't make it a surefire win. It never will. I still haven't worked out what makes it a surefire win, but they make it more likely.
That's really good. I want to make sure we spend some more time talking about community building and developing these environments, but I also want to give more context on what you're doing now, because you've already mentioned so many different organizations and so many different endeavors and interventions you're a part of. And I do want to talk about the lifestyle clinics as well later. But I'd like to get a little bit of sense of, I sort of feel like you have your fingers in lots of pies. You wear lots of hats. So can you just tell me a little bit about the different organizations you're a part of, different hats that you wear, just so that our audience can get a sense of the different things that you're currently working on?
Yeah, of course. So the Royal College of GPs. I'm one of the lifestyle and physical activity champions alongside Dr. Callum Leese, who's up in Scotland up there with you, Andrew.
He's a good guy.
Um,
Yeah.
I also at Red Whale, which is a primary care education platform, one of the biggest, in fact. I'm the lifestyle and obesity medicine lead there, so leading their courses, and that really does reach out to a huge population of healthcare professionals. And it's a role that I take really seriously because I've got the opportunity to try to support them to support their patients better. And I think that I really see that as fantastic reach and a fantastic opportunity that I want to do my best there. I work at Parkrun as the health partnerships lead. And you may know of a number of initiatives that we do at Parkrun, like the Parkrun Practice Initiative and Junior Parkrun, etc. I am on the board, the Health Commission board at Swim England. And through that, I work very closely with a charity called Mental Health Swims. We launched the first Swim Together group based in the primary care network that I work in, which is a accessible entry-level swim group where you don't even need to swim. Actually 2/3 of the people that attend can't swim, but it's using the water, getting them more comfortable and confident in an environment like that. And the final role, and probably most important, is the one where you're on the ground, and it's at the Leamington Primary Care Network as the personalised care lead. So that's supporting a team of social prescribers and health and wellbeing coaches, delivering things like the lifestyle clinic plus sort of one-to-one support with patients.
Great. And do you have a formal role for British lifestyle medicine or?
Oh, so yeah, the British
Yeah.
Society of Lifestyle Medicine.
Yeah.
No formal role there,
Uh,
but always happy to contribute with the
yeah.
sort of sessions and conferences and that kind of stuff.
Yeah, it's good because I mean, I mean this in the best way possible. You're sort of everywhere in a really good way. I find that if I go to a health conference, there's a very good chance I'll see you, or you can give a keynote speech. And obviously you've got all kinds of blogs and things. So it was a real pleasure when I was preparing for the podcast, just to see there's no shortage of
I'm
of,
sorry.
uh, of good things to talk about. Um, all right, so I think the audience has a sense now of the different things that you do. And so you do park run. I know you've done run, talk, run, the mental health
Mm.
swims, all these different things. And I heard an interview, maybe I read an interview with you the other day, and you used a term which I thought was very good. You were talking about this idea of whack-a-mole medicine
Hmm.
in regards to average appointments per person per year. And I think that's maybe a good place to jump off to start talking about the idea of social determinants of health, or creating a healthier environment, or maybe lifestyle medicine. I mean, it really touches on all those. Could you kind of talk about what you mean when you talk about this idea of whack-a-mole medicine, and perhaps maybe there's a better way or more holistic way of looking at health?
At the moment in primary care, for the majority of the nation, the method of supporting patients is through a 10 to 15-minute appointment, either on the telephone or face to face. And that's great if you come in with, I don't know, a chest infection or urinary tract infection, or maybe you've got a musculoskeletal injury that needs assessment. But for the vast majority of long-term conditions, 10 to 15 minutes in an appointment face to face is useless.
Yeah.
Okay. I'm sorry to say it, but it is only ever going to be firefighting. So what I mean by whack-a-mole is that you're just whacking the mole that you can see popping out the most at this one instance and just hoping that they're not just going to pop up elsewhere, because they will. And we often talk about, oh, we need more GP appointments, but I just don't think we do, because when we look at the stats, and I've got them in front of me to make sure I've got it accurate. In the 1990s, the average number of appointments per person per year was between 3 to 4. Okay. And then if we go to the late 2010s, I think it was 2016 at this figure, it's now over 7.5. So we've nearly doubled. In fact, no, we've more than doubled the number of appointments per person per year. Now, we aren't half as sick. We are now got more long-term conditions than ever before. We have a reducing health span. We have a reducing, for the first time, life expectancy. And we've got really high burden of disease. People are suffering with more symptoms, more illness. If the appointments were the answer, we would have done it. Because remember, that's appointments per person. These people are getting these appointments. And so when are we going to stop and think that we are not providing the medicine for this ill? This 10 to 15 minute appointment is not sorting it out. And I was experiencing that, as a GP with multiple sessions, just sort of seeing patients one to one. And I was thinking at the end of the day, I was like, how many of these patients have I actually really made a material difference to? And I was struggling to find, outside of the acute presentations with the simple issues, single issue, and I can enact a clear management, I wasn't helping the type 2 diabetics. I wasn't helping those with heart failure. I wasn't helping people with osteoporosis like that. Nothing was really happening. And I was getting frustrated, and I wanted to think about delivering things differently, because if I wanted to support people to make their own improvements in health, because in reality, the vast majority of health, happens outside of the consultation room, where I no longer have any influence on. And so if I want to bring up these kind of discussions and empower the patients, how was I going to do that in 10 to 15 minutes? If I said it as a few minutes at the end of an appointment, it would either come across as judgmental or it would be ineffective. And I think what I wanted to do was, how do I get the opportunity to spend more time with these patients realistically? Because if I set up 1 hour appointments with patients, no one's going to allow that to happen. I would get through maybe eight patients a day. No, most GPs get through about 40 to 50 patients a day. So that's not going to work. So then I realized that what I need to try and do is instead look to get the patient in a different environment where they can get peer support from each other, where we can get community support from all the various organizations that are doing incredible work in the different facets of health. Let's get them all in the room and let's do it over an hour. So instead, I've got 8 to 10 patients for that hour, which is slightly more than what I can see one-to-one. And suddenly, all I needed to do in the sort of 10-minute appointment was just to encourage them to come to this session. Say, do you know what? We've just opened the door. We've just opened the door on this. There's so much more that we can discuss, and I want to learn from you and maybe present to you to see what you think. How about come to one of our group lifestyle consultations, etc.? That is an easier sell, and I think a more effective use of your time. Yes, you still have your classical 10 to 15-minute appointments for a certain proportion, but we need to start thinking about delivering other forms, whether it is group consultations or community sessions, or even bringing in other organizations and other expertise to support our patients. Because at the end of the day, 10 minutes, prescription model, that will only help a certain proportion of the patients that we see. The vast majority, they need a different medicine.
Yep. I mean, you said a lot that we could follow up on. It's funny because there's that theory of iatrogenesis or iatrogenic harm, which is this idea that actually increased medicalization is often correlated with worse health outcomes, more comorbidities. And obviously, I don't think it's causative, but there's something about the narrative, I think, as we perhaps offload a lot of the old social systems that maybe work, support, maybe even food production, things like that, as we medicalize it. I think as we both know, there's a limited amount of good you can do via prescribing pills and things like that. It's a much more holistic, much more thorny, joined up thing. But then I was going to go in that direction. But then you started talking about the group lifestyle consultations. I think that's really interesting. I think our audience would like to know more about that. So can you just talk a little bit about the structure of these? How do they work? Are they like a finite set multiple week program? Are they ongoing? And just what would a session look like?
Before I describe the structure, I'll just sort of crystallize the aim of what I wanted to achieve with them, which was I wanted them to be a space where the patients could feel unpressured, could ask any question, no matter how silly they think it is, and where they can start to feel empowered to make decisions around their own health. It's
Mhm.
not me telling them what to do, but it's them deciding based on having more informed understanding of what the current situation is. So, with that in mind, I wanted to get the right people there. So, if we start off, how do we actually funnel patients into these sessions? So, there's three mechanisms. One is patients can self refer. So, rather than having to have a problem and speak to your GP, even before you have a problem, if you want to come to the lifestyle group consultations, you can come. So you can self-refer through the website or via social media, one of the links that we have, and you can do that. You don't have to have a long-term condition. Because that's another thing that I think is crazy. Like, why are we waiting for
Yes.
people to have problems to try to find solutions? As
Yep.
we all know, and we keep saying it, we don't ever seem to enact. Prevention is better than cure. So you can self-refer. Brilliant. Second is referral from your healthcare professional. So, as I described before, you're having an appointment and they go, "Oh, why don't you come and attend? I can refer you to this group." So, that can be done by anyone. It can be done by the reception staff, the nurses, the doctors, anyone within our team can refer. The final one, I think the most important one, is what we call population searching. So, this is specifically trying to identify those in our community that have the greatest need, but have the least opportunity to access services. So, we do searches on for that. We try to find those with the highest health issues and with various different markers that we feel that may be barriers for them wanting to attend. And we will actively reach out to them. We will send them either text messages or give them a cold call to offer them as to whether they want to engage with our groups.
Mhm.
Once they attend, it's made up of 4 sessions. The sessions last for an hour and a half, and it's made up of 1 hour of group discussion in a meeting room and half an hour of movement. That movement could be a walk, jog, although most of the sort of sessions we do doesn't include a jog, based on the kind of sort of entry level that we get, and a swim. And those sessions run once a week for 4 weeks for the 4 sessions, but then that half an hour of movement at the end, that always runs. So once you've
Ah,
completed those 4 weeks, you can keep coming, and we want you to keep coming to that
yep.
half an hour bit. Okay. And it's great because it allows us to keep connected and following up with these patients for as long as they want. They don't ever get discharged. They will naturally find a time where often they will then join another physical activity group because they feel more confident, or they will progress onto the next step in their journey. But I find that's really important because whether you do 4 weeks, 8 weeks, 12 weeks, the problem with those sort of finite sessions is that suddenly you get sport, 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 and then done. You've
Yep.
been discharged. You're now on your own.
Yep.
And I think it's really important that we consider, what do we do for that exit point? It should never really be an exit. It should be like a transition.
Mhm.
And that transition for some person may be 5 weeks. For others, it could be 4 years.
Yep.
We've got patients that are still coming that still get benefit, and it's been like 5, 6 years now. Good
Mm.
for them.
Yeah.
And because it's a different amount of time that we each need. And there's others that, they've come to the 4 groups, they come for a couple of weeks afterwards, and then they move on to something even better. Like they will then join another, let's say the local leisure centre, or they'll join the Tai Chi group happening at the nearby lake, or, they'll use it as that stepping stone, and they'll find the footing very quickly. And these sessions are not about education, but they're about facilitating discussion with education injected at the points when they ask. So we get them round, we get them talking, we get them finding out what are the sort of expectations, what do they want to get out of it, what are their thoughts. And then I'm there as sort of a, expert, inverted commas, providing information for when they want. And Joe Fleming, so my colleague, who's a health and wellbeing coach, is there to help facilitate and to help, draw out some of the questions they may have or thoughts they may have. And so it may be, let's say they're discussing about nutrition and they're wondering, what's the best thing that I should be doing now that I'm in my sort of late 60s and I want to try to maintain my function and my muscle strength, etc. What should I be doing? And that's where, they discuss as a group and they may go, oh, Hussain, what do you know about this element? So therefore, I'll then inject a bit of knowledge, and then Joe will help them find out what do they think about that. What are the thoughts about that? How would they want to implement it? So what I think is really important, that this isn't a session about me telling them what the perfect lifestyle is. It's more a session for them to find out what is it that they want to do to get themselves to a place where they want to be.
Yes.
Because the perfect lifestyle doesn't exist.
Nope.
It's different for each and every one of us. And I really mean that. Like, optimal lifestyle for each of us is different depending on our circumstances, our environment, our genetics. And so what we try to get them to do is understand that personalization doesn't come from me applying it to them. It comes from them deciphering it for themselves.
Well, that's very good. I've got 3 follow-up questions on this, so I'll do one at a time. What have you learned the most from these group lifestyle consultations? Like, what have you personally learned and gotten out of this?
That I don't know all the answers, because when I started it, genuinely, I had the belief that I was really knowledgeable, and all I had to do was give them my knowledge,
Yes.
and they would succeed. And it took a little bit of time for me to realize that I know nothing, and I'm now accepting that, and I now accept that I don't need to know everything.
Yeah. No, it's I think you're right. What you said about facilitating an environment where people can sort of learn what's important to them, sort of find out their why, and really sort of create some, I'm not going to say solutions, but create some tools, some ideas, some habits that can help them move towards that. I think that's very powerful.
Exactly. And I think what I realized was it's all around not me not knowing the information, but not me not knowing them as they can know themselves. And I now teach to, when I try to explain, because often they want me to give them the answers. Often they ask me, they go, what would you do? I want to know what you would do. And I draw out a big kind of iceberg and I say, this tip at the top, that's the bit that I can see. Okay, because of what you've just described to me. You can't describe all of you in an hour, 4 hours, or maybe even 4 weeks. And so I can only see the tip. And I use this acronym called TOY. So T stands for the idea. So I say, because you can see the whole iceberg that is you, you're going to come up with likely the best ideas. So that T is for their ideas. O is other people's ideas, because they can see more than the tip. They can see a bit deeper. They know you, whether it's your partner, your family member, etc. They can't see all of it. They never can, but they can see far more. So if you're really struggling to think of your own ideas, ask them. Ask them for their thoughts.
Yes.
So that's O. Y is finally you, the healthcare professional. That is where, if you have exhausted all attempts of trying to generate sort of ideas and thoughts, then think about how you could apply your understanding of that tip to generate ideas for the individual as a starting point. Not going to be the big decisions, but just a bit of lighter fluid to get them to start thinking more broader. I've rarely ever needed to get to why. Nearly always T will work with the right support and the right environment. And then O will help out. If they're really struggling, they can think about speaking to someone that's close to them. Sometimes even asking them, what do you think your partner would say? Or what do you think your loved one or very close friend or family member would say? That suddenly generates ideas around that and reflection on that.
Yeah, it's interesting how sometimes putting yourself in the role of someone else can really clarify. It's one of the things I always think about when I'm trying to program for myself or come up with a bit of advice. it's really interesting to put yourself in someone else's shoes, and often that can just sort of cut through a lot of the narrative. Two more questions about this. You did mention working with Joe Fleming and health coaches in general, but I know, so within, should I say within Leamington, or should I say within Warwickshire? Would be more accurate.
Leamington.
Leamington, okay. Within Leamington, Leamington does have health coaches that work in conjunction. Okay, great. And you also have social prescribers?
Yep. We have 3. Incredible. 2 for adults, 1 for children and young people.
Could you just talk about how both the health coaches and the social prescribers work as part of sort of the network? Can you just kind of tell me about their roles and sort of the teamwork and the different remits for each of them? I guess so that would be GPs, and I'll say doctors and nurses as well, and then health coaches and social prescribers. And just tell me about how the system works together.
The health coach, who's Joe in our area, she will support patients she'll do the group consultations alongside myself. She will see a certain proportion of those patients that have come through those groups for one-to-one coaching support as they work through specific goals that they've generated. Now, the social prescribers, they will support in particularly the events that we run, that half an hour movement. So Snay, who's a very, very keen walker, she comes and she leads the walking group, and the walk is always so much more than a walk. Like, really, the walking is just a side effect of just spending time talking about our community, about, our kind of environment and the nature. And we spend as much time as we can, accessing our local country park and the parks within the town. And the social prescribers, they will see patients that get referred directly to them, either via reception, because the patient rings up and explains that they have an issue that's non-medical, and they will support with, whether that's accessing financial support, further education, food banks, whatever that may be. They really do see a diverse range of the population. Now, they see most of the patients initially with sort of a telephone kind of triage to try and understand what it is. But then many of them, they will go out to the community and they will support them and try to connect them up with the community offer. Because often they're described as link workers, because they link the person with the various different offerings within the community that may be helping them. So maybe it's someone that's lonely and isolated, and they'll link them up to the local group that's based in the church, where they do coffee lunches and connecting experiences in that sense. So they're really important, they're really valued, and they play a huge role when it comes to supporting patients, and in particularly supporting them in how connected they feel to Leamington.
The last question on this is, with these lifestyle consultations, these group ones, it sounds like a really interesting program. Is there any work to expand them? Or if someone is listening to this podcast and they think, this is really what my community needs, how can people try to make this happen where they are?
Yeah, so with the support of my local active partnership, Think Active, about a year and a half ago, we basically drew up the key kind of blueprint, whatever you want to call it, the ingredients that it is that makes this. And we asked if the other primary care networks in Coventry and Warwickshire were interested in delivering it. And we had a really good response. And so they supported 9 other primary care networks who I mentored through in regular monthly meetings and discussions to deliver the same thing. And in fact, last week on Monday, we had a conference both celebrating and highlighting the evidence completed by Coventry University, who did an external evaluation of these new 9 primary care networks and identified that they had made a big impact on the patient's activity levels, the readiness for change, the confidence, and the physical and mental health. And so that was a great sign to see that even within the first year of setting up these clinics, they were already having a therapeutic benefit. And the staff at the various different PCNs really valued being able to deliver care in this way. I think it's quite rewarding for us, having the ability to really do what we often came into medicine for in the first place. And from that, on the Royal College of GP's Physical Activity Hub, so the section of our website, if you just Google RCGP physical activity, you'll see on there the sort of structure and the details of how we delivered both Leamington and those other 9 PCNs. They're all there. So there's like a toolkit there that you can download, and it's got all the details and the informations and the nuance. And my key tip to anyone that wants to try to recreate this is, yes, use that as a really useful guide.
Mm-hmm.
But what we found with all 9 PCNs, they all delivered it slightly differently.
Yes.
And that's because everywhere is different. The different staff have different expertise in different areas. The different needs of the community is varying. The actual physical space that you may have may dictate how and when you will deliver these sessions. So you have to understand that this isn't some like perfect formula that I must recreate and it will create the magic. The magic comes from just shifting your perspective on how you want to deliver care, and that you don't have all the answers, but you can create an environment that is therapeutic for the patient, for them to find them out for themselves.
Very good. Yeah, I read the report and the summary, and it's just really really interesting, and it would be great to see how other groups and communities implement some of these ideas, because I think there's some real gold in there. I think you did a nice job of explaining what worked and why it worked, and how other groups can look to implement that. You said two interesting things while we were just talking. One of them, you made a comment about this feeling more like the reason you got into medicine in the first place. And a lot of practitioners have said that, is that a lot of the hands-on stuff is rewarding in a way that these 10-minute appointments can't be, or these,
Mhm.
prescribing, certain medications to take care of something that you sort of suspect, could be mitigated by more physical activity or reducing loneliness, things like that. And the other thing that you were talking about, which well, you were talking about empowering. You were talking about shifting the narrative. That's right. You're talking about shifting the perspective. And this has made me think about something that Jill and I have been thinking about a lot recently, mainly because we had 2 anecdotes that we heard from some of our members recently, and one of them was caught running to they would have been in their mid 70s. They were caught running to their GP appointment, and they were sort of admonished by the GP because they're out of breath. They said, you shouldn't be running at this age. And then someone else who was told that at this age they should stop carrying heavy things. So like if they're gardening, they shouldn't pick up the bags of soil and everything. And this wasn't in relation to a hernia or acute back pain. It was just given as general advice.
Hmm.
So I'd like to talk a little bit about narratives. I'd like to talk a little bit about the role of GP and medical professionals in creating these narratives, and how these comments can have these long, because if you give someone that advice at 65, you should stop running or you shouldn't pick up heavy things, that's going to cause a cascade of downstream effects. If they're alive for another 20 years, you think how, because people do respect GPs so much,
Hmm.
they'll take that idea and they'll really internalize it. So I want to talk about narratives. And then also, I want to shift the few minutes we have left to talk about just this idea of healthy aging and active aging. So I'll pass the mic back to you.
Yeah, so important. And we know that patients do listen to what we say. And as you say, like it's the length of time they hold on to it.
Yes.
I've heard so many stories. And like hearing that both those examples you've given, then it's disappointing, but it's not surprising. And I've heard it many, many times. If we think about it, clinicians have been trained in a certain way, and it's led to certain narratives and beliefs becoming widespread. We get 5 hours of training on physical activity
Yep.
in the 10 years in total that it takes to train a clinician. And what does that tell you about the importance of that thing?
Exactly.
Exactly. And so, and I asked someone this. I was on a panel in a big conference, and they said, "Okay, you only get 5 hours because physical activity is simple. You know, it's straightforward. You know, the drugs and everything like that. That's very complicated."
Mm.
But then I said, "Surely the time spent learning about something should be based on the potential impact that that thing has.
Yes.
Or at least that needs to fit into the equation. So it can't just be based on what you perceive as simple, because I would say that it clearly isn't good enough, because the advice that we're giving often is harmful. For example, that lady that now may stop running, that is the last thing she should do. In fact, the opposite. She should do whatever she needs to do, not just to do that run, but then to do other activities that means that she can run safely.
Yes.
She needs to make sure that she's prepared her bones and she's maintaining her density, that she's preparing her joints, and that she's doing a proper warm up, and that she's allowing range of movement of her joints, that they don't become stiff and increase her risk of injuries. There's so many things that she should be doing more of. And in fact, Sir Muir Gray, who he's the godfather when it comes to physical activity in healthcare. He says that physical activity is something that you should do more of every single year. As each year goes on, as we get older, you need to do more. He goes, that may not always be time, but it may be in specificity. It may be in intensity, in a certain format. And the other thing that he often says is that caring and supporting our loved ones, our older relatives, is the worst thing you can do. He says we need to enable, not care. It's not about, I'll get you that, Dad. I'll get that from the kitchen. Leave the bags. I'll take the bags. Because what that does is it just massively accelerates deconditioning. And that deconditioning leads to aging. Aging really, it's not, we think of it as the passing of the clock, but it isn't that. It's more complicated than that. It's the deconditioning of the body. It's the building up of frailty. So there's some people that I've met in the mid to late 50s as patients that I would say have an older body biologically than one of my patients that's 96. And I know I've got him in my head right now, and he is active. He still cycles to the practice when he comes to see me. He does a 10-minute sort of stretching and movement routine every morning when he gets out of bed. He is strong. When I did a timed up and go test. So basically, I time my patients from the waiting room to the consultation room as a bit of a guide for me to know kind of where are they physically. And he outperformed on that day all my patients, even the ones in their 30s. Okay, he just up from that chair straight into my room. And the thing is, you may think, okay, why does it matter? Why does it? Well, it matters because he at 96 still goes and visits people in the town. He still does his own shopping. He washes himself. He prepares his own meals. He hasn't had to move his bed to the ground floor and get a hospital bed. He is still living life. And for many that I see, they're in their mid 60s and 70s, and their world has shrunk.
Exactly.
They can't leave the house that often. Even coming to see me is a huge physical ordeal. And they can't go to the cafe. They can't like that patient. He goes and watches the rugby. He still loves the rugby. He goes to the local Leamington group. He walks 3 miles there. It's a mile and a half there, mile and a half back. He does that. It's not a problem for him. And so when I try to explain why we need to be getting active, it's not to lose weight. It's not to, to even like lower risk of this or lower risk of that. That's all great. But it's to be able to do the things that you want to do for as long as humanly possible.
Exactly. That's it's one of the things we think of all the time. I mean, obviously, working with older populations, people talk about fear of falling cycle, but you see this generalized these fear avoidance cycles, where, as you said, people's worlds just get smaller and smaller and smaller. The question is, what can we provide? What tools can we give people? How can we facilitate this sort of virtuous cycle so people can start engaging with the world again, exactly doing the things that are meaningful for them? How much time do you have left, Hussain? I've got 2 questions I want to ask, but I don't want to.
You've got time for that. Time for
great.
that.
Perfect. So one of the things that strikes me is we have so many great options now for social physical activity. I think we've got Parkrun, which is amazing, and it's just been such a boon, to the UK, but really worldwide now. And we see these walking groups all over, done by various organizations. Fantastic, because obviously we know that they're helping with loneliness and social isolation, all these other things. Every intervention is much more complex than I think we give it credit for, because we don't always take into account all the other factors that are embedded into it. But what's been interesting with us, I've noticed, is I think that the messaging on strength training, resistance training, progressive resistance training, has really started to make its way into the general conversation. People are much, much more aware of it than they were a few years ago. And generally, there's much less pushback. And often I'm very impressed when I see older members, older clients coming in and talking about it. So I think the messaging has worked. But a couple things strike me, which is that with a lot of the social movement, social physical activity opportunities, most of them are still, at least notionally, about cardiovascular conditioning. Are about this idea of walking, running, which has this whole host of benefits, and is obviously much more, because for some people that is strength training. Running, especially if you take the time to build your way up to it, you have that impact, which if you get the dose right is going to be fantastic for bone density. Swimming, obviously great full body movement, so many benefits to it, and also a form of resistance training, especially as you increase intensity and things like that. But then, I look at some of the recommendations that we see on strength training, specifically for things like how do you increase bone density, or how do you offset sarcopenia and things like that. And it seems to me that there actually aren't a lot of opportunities for people to hit some of these clinical recommendations that they see. Um, and often the recommendation seems to be going to the gym. And what I see right now is a lot of the, I'll call it the conditioning, seems to be done socially, but there seems to be this implicit assumption that strength training is a personal practice that is done in a gym by yourself. And that's something that we're trying to fight at Wild Strong, but I think it is challenging. So I'd like your take on it, and I'd like to see what kind of solutions or recommendations you give people to try to get in some of the benefits of resistance training.
Yeah, I think it's good to see that, as you say, strength training is becoming more prominent and widespread outside of the usual groups. Whether that be amongst women and amongst older people. It's getting there. I don't think we're there yet, but I
No.
think we're definitely heading in the right direction. You're totally right. There's so many fantastic assets currently operating, doing great work in so many different modalities when it comes to physical activity.
Mm.
I do wonder why we do not incentivize the creation of those groups more. When we think about all the things that are currently operating commercially that often bring harm to
Mm.
our nation's health. You look at most of the high street, let's be honest, most
Yeah.
of it isn't bringing benefit.
Yes.
Okay. It's bringing up. And then what support do we give, this sector, the physical activity sector? Because they're bringing us benefit.
Yeah.
Not only, yes, they're doing the job, great, but they're actually actively reducing the bill of the
Yes.
healthcare, they're reducing social care bill, et cetera, et cetera. And I do find it mad that we do not incentivize and really try to catalyze what they're doing, because they could be doing so much more.
Yeah.
And it's not through their fault. It's just through the fact that they can do as much as they can with the
Mhm.
resources they have and the access and marketing that they can do. Now, the sort of question there with regards to, how do we go about actually delivering training on strength for patients? I think it's so important that it is diverse, both in the application and the location and the style, because people need different things and often at different
Yeah.
stages of their life. And we can't expect everyone to get the correct dose at
Mm.
the gym.
Yes.
You know, about 15%, 15 to 17% of the population have a gym membership. It has improved recently, hasn't it? Which is fantastic. And it's good to see that more people are incorporating that. But I think that there's a whole untapped proportion of people that would be able to strength train if it was in a different format for them. And so both, I think the leisure sector and the gyms, the sort of the gym centers can be fantastic places. And they're already doing great work. And I think there's even more work they can do to broaden their appeal beyond that percentage and get more of the cohort. But the right thing is 100% of people are doing some form of resistance training. For others, it may be CrossFit will be their thing. I know that it was something that you used to be into previously, and very much so. And that may be that thing for them at that stage. But there's so many other levels that are currently missing. It's kind of like, unlike cardiovascular exercise, which I think has more nuanced options and choices that you can pick from, we haven't got the same selection to pick from in strength training. And I think we should. I think we should look to use more of the outdoor environment. I think we should look to use more of the kind of creatives, whether it be using music or dance or other elements. There's so many ways we can make it more, I don't know, more interesting or connecting experience for more people. Because what I want is for people to have a way of accessing strength training that meets their needs at each of the stages of life.
All right. Thank you for that. It was a good answer. Final question is, what are some trends that have you feeling optimistic right now? What are some things that you're looking at? You think, well, you know what? Actually, I think in some ways things are moving in the right direction. What has you feeling optimistic right now?
What has me feeling optimistic is that more than ever, when I'm delivering a session or one of my colleagues in this space are delivering sessions or talks, people are coming. When I say people, I mean the healthcare professionals. They're coming. I remember when I first started banging on about this stuff, empty rooms, mate.
Yeah.
Like, just people just weren't engaged. They didn't get it. It wasn't our role. I even got a lot of negativity, if I'm being honest. Now, other way around. At the annual conference that we did, there were two sessions happening at the same time. One was around a new drug, which I can't remember what it was, but they had a giant room. I'm telling you, like they had a big room packed out, and they had lots of free stuff that they would give the people that came. Like there's like nice food, there's all this cool stuff. And then across the way, there was myself and my colleague Andrew, and we had a pretty rubbish room, no free things, unfortunately. And we were talking about physical activity, and the room was rammed.
That's great.
Like it was spewing out onto the foyer area, and people were sort of Chinese whispering like what was being said, like they were just passing it along. And the room, with the new drug, like that was massive. Barely anyone was in it. Okay, barely anyone was in it, and that made me feel. I was like, do you know what?
Yeah.
That a change is coming. A change is coming, and more healthcare professionals, they're not happy with the state of play at the moment. They want to start delivering a more wholesome, more patient-centered, more caring, and also I often use this term. I don't know even if it's right, but it's more fun.
Yeah.
Like it's just more fun. If I'm able to help patients get more fun in their life, that's my main goal. Like I want to see them laughing, smiling, having a good time. That's winning. Like it's not just that the HbA1c has gone down by 2 points, or the blood pressure mercury has gone down by, let's say, 5 points. Like that's great. And don't get me wrong, of course we should still measure those things.
Yes.
But at the end of the day, I just want them to enjoy life more.
Yep.
And in doing that, that's rewarding. When a patient comes and tells me that, like all the things that they've done and the places that they've gone to now and how like move. And actually, let me just give you an example just to finish off.
Yeah.
There's a lady, she was one of the first people to come through the lifestyle clinics. It was now many years ago, but mid-50s and really going through a difficult time. She'd been recently divorced, gained a fair bit of weight, kind of always smoked socially before, but now was smoking a fair bit. And she had been diagnosed with high blood pressure and she was having some angina symptoms and she was all getting very worried. So she came down and we spent time talking to her, and she started, really starting to change her outlook and her focus. And cut a long story short, we get to a point now, 6 years later, like she has reconnected with her children, who she got quite disconnected with through the divorce. She has lost a huge amount of weight.
Mm.
She runs regularly. She goes to a local dance group. She does strength training at home with resistance bands. She travels like all the time. Okay. She's always telling me that she's gone here and gone there and been this and been that. And the biggest thing is the woman that came into the room, she looked like she had no hope when I first saw her, just really, really withdrawn. When I see her now, she's got the biggest smile,
That's great.
the biggest smile. And instead of sort of slowly,
Mm.
difficultly having to go down the stairs because she didn't feel very comfortable, she now runs. You know,
That's amazing. Yeah.
she's Irish and she went and did the Cork Marathon.
Wow.
Okay. If you
Yeah.
asked me then that is this woman ever going to run 5 kilometers, I'd have said no way.
Yeah.
Like, not even possible. In my head, even back then, I was like, "Oh God, is it even safe?" Like, I don't even
Yeah.
know.
Yeah. Yeah.
But like, I think she's run like 6 or 7 marathons now.
That's amazing.
I can't even
Yeah.
keep count. But she just shows you how far you can go. And I and Joe and whoever, we did nothing apart from give her a different perspective, and a different approach. And then she's done all of that. She's incredible.
I think that's a great example. And it's true. It's amazing how many of these things that we assume are inevitable or we assume are just up to aging, whatever that is, they're not. You don't need to be fatalistic about this. So much of this is reversible. The body is adaptable. And I think you're right. It's just about changing that narratives, creating better environments. Again, thinking about that salutogenic environment where people can really thrive and flourish. And it is amazing to see how people can bounce back. So,
She's biologically younger than when
yes.
I first saw her 5, 6 years ago.
When
Like,
you see people who reverse the shuffle, people who regain their gait after something that, I don't think is an exaggeration to say almost feels like a death sentence. That when we see people get that, it's amazing. And, in terms of reward, I think there's almost nothing more rewarding than seeing that happen in somebody. And then, going back to what you're saying, it's that fun. It's giving people that sense of hope again, and letting them know, hey, you can still engage in all these things that make you happy. You don't need to feel like you're a prisoner in your own home, or you don't need to feel like you're a prisoner in your body, because and everybody's different, but it is amazing, the progress that people can make. So,
yeah,
well, I think,
and often when we're trying to achieve a goal, often in healthcare, we're just so laser focused to go, okay, what can we do to get that goal? So maybe for her it was to reduce her smoking, or
yeah.
maybe it was to increase walking. But that's in my opinion not the right way. Like, for her, like, the first thing that sort of she had agreed that she was going to try out was to do something once a week that
Mhm.
brought her joy. And that
Yes.
was actually going to the local like comedy club,
Yeah. Great.
kind of thing. And that was going to be her time. She goes to
Yeah.
the comedy club,
Yeah.
she's going to do that, she's going to enjoy that. And it's something that she used to do when she was younger.
Yeah.
And just doing that, just it set off those goals. And nothing that we didn't specifically say, now we should work on your cigarettes, let's
Yeah.
reduce that. We never did any of that. That happened sort of naturally. She started to want to walk a bit more, and so then she go, oh, I want to try running. And then when she tried running, she goes, maybe if I reduced how much I was smoking, this wouldn't be
Yes.
as difficult.
Yes.
And then she started naturally just reducing that, and then she didn't have the urge to do, like, these things start to happen naturally. You don't have to feel like
Yeah.
everything has to be planned out and specifically targeted, because all it is just create that environment, and the rest will happen as long as you continue to work at making sure that environment is nurtured.
Yeah. I think sometimes we're limited by the way that we talk about what is pleasurable. Yeah, and what I mean is, the Greeks, they have that great old term eudaimonia, which is this idea of what contributes towards the good life. So it's not things that are immediately
Mm.
pleasurable, or it's not putting off things you don't want to do, but what are the activities that allow someone to flourish, to thrive? All the what are the things that are good in life? And I think it's so, as you were saying when you're talking about what the high street often provides,
Mhm.
you see and you think of how many high streets in the UK now are essentially vape shops,
Yes, exactly.
or fried chicken or things like that. You
Yep.
see all these things that compulsively are there to be consumed, but very rarely make people feel better. And it is interesting once you sort of break that cycle and people can start identify what is it that really makes them feel good, how all of a sudden we can create this virtuous cycle. And I think the giving up the cigarettes, not because your doctors told you to, but because you recognize that actually you feel better. I
Yeah.
think for anyone who's had a really active university few years, when you stop drinking like a university student,
Mm.
actually it feels pretty good not to be mildly hungover all the time. And then
Yeah.
you just start doing it. It's the same thing. You take the first few steps where running no longer feels like an obligation. It doesn't feel like something you're supposed to do, but you actually
Yeah.
get that first runner's high, or you actually realize that you enjoy having some time to yourself. And I think that's really
Mm.
it. It's just, showing people that, as they often talk about health promotion, the healthy option should be the easier option or the more desirable option. I think it can be, once people have the opportunity just to experience how good things can be.
Often it
If
doesn't need to be easier than the kind of harmful option, but it just needs to be close enough. It needs to
Yes,
be within reach.
yes, you need that adjacent possible. You need to know
Yeah.
exactly. I think within reach is a good way of
Yeah,
putting
because
it.
for a lot of people, it's out of reach in how
Yeah.
it's sort of set up and their environment and their opportunities. Like it's just too far to realistically expect someone to, go the lengths of the earth to try to reach that healthy option when
Yes.
everything else around them is just conveniently there but causing harm.
Yeah, it's complex. I mean, it'd be nice to get you out in the future
Mm, I'd love
to
to.
talk about some of these more thorny issues because I think as often happens we start talking about this. We do look at the deep systemic pressures and how how do we go upstream? How do we really start looking at, as you mentioned, all these incentives, these economic incentives, these perverse incentives that often will reward certain kinds of businesses or certain environments. And it's complicated, but you know what, it's like you said, this is becoming more legible. And I think the conversation about this has become so much more astute. And I think
Mm,
there are very few good things that came out of the pandemic, that came out of COVID, but I think it did help crystallize what's important. I think people realize that face to face relationships, being outside, being able to move your body and have access to green space and all these things that are really, really important. And, it also helped people realize that doing everything on a computer is not good for us. While they are great tools and they're allowing us to speak today, um, I think that we have a better understanding of what's important for healthy society. Um,
agree.
Hussein, thanks so much for your time. I really appreciate it. I really enjoyed that. So thanks. I'd love to get you on the future. We can start to untangle some of these deep things. But yeah, really appreciate it.
Appreciate it. Thank you.
Day, night. It's a daily exercise. It's a daily exercise. It's a daily exercise.
And we're back. Wow, there was a lot in there. I think that's the sort of episode that you need to go back and listen to with a pen and paper, a bit like the Eugene Minogue one. Thank you so much to Hussein for agreeing to come and speak to us and giving us so much of your time. I thought that the part around a better approach to healthcare, a more holistic approach to healthcare, but it's not just about lowering blood pressure, but just about, bringing in more dancing and laughter and joy. That's the kind of medicine we want to see more of. Yeah, well, there's a lot in there. I hope you enjoyed that one. I've put in some of the links in the show notes to what we were talking about, particularly around the Royal College of GPs toolkit for group consultations and all sorts of other links that Hussein has mentioned. So have a look at those. If you enjoyed this episode, please do subscribe. We say it every week, but it does make a big difference. We're a tiny podcast and the subscriber numbers matter. If you think it's a really good episode, a particularly interesting episode, which it was, you could also leave us a review. That would be lovely too. Next week, we'll be back with Cliff Harsky, who has been in the sort of strength and conditioning circles for a long time and helped with Rafe Kelly to create MoveNat. He's just got a whole wealth of experience around coaching movement over the years and how the trends have changed and kind of where he's ended up, and a bit around sort of the weirdness of social media and all sorts, really. It's a very good chat as well. I'm just really enjoying these chats. Anyway, have a lovely week and we will be back soon. Bye.